take the calls, that would be.
Okay, Tim, we'll just wait a couple of moments for others to join, and we'll get going at 2 o'clock precisely. But lovely to see you, David and Karen, on the line.
Hi, yep, I'm here. Thank you for the invites.
That's our pleasure, David. Thank you for everything you do.
Grant is on his way. There was just some slight confusion. Do we attend? Was it virtual? So he went attend, I went virtual, and I won.
Okay, no worries.
But he'll be here in a moment, so I do apologise.
Okay. Okay, ladies and gentlemen, well, welcome to this, the September SWFT board. Absolutely delighted to see so many members of the public with us. Just before we get going into the Going the Extra Mile Awards, I just want to thank a couple of colleagues who are joining us from holiday, David Spraggart and Richard Colley, and also to celebrate that this is the last board where we have Sarah Moppet with us. Sarah stepped in when Fiona was away and did a fantastic job looking after Fiona's portfolio, and over the last few months has been working as our Director of Recovery and Care Excellence. But Sarah, you were absolutely wonderful to have as a colleague. I'm devastated that you have decided to go to pastures new, and we wish you well, but also many, many thanks for all the incredible hard work you've put in Fiona's absence to continue to nurture all of our nursing team. So Sarah, you leave with all of our best wishes. And whilst we're celebrating colleagues who go the extra mile, we have our Going the Extra Mile award winners. And first up is our individual winner, and that's Karen McGregor, who's a medical secretary. Hi, Karen, nice to see you. All those files behind you tell me how essential medical secretaries are to the effective running of the trust, and often the unsung heroes. But I just want to read out the nomination that Karen was sent. Karen works in the Family Health Division. And it said, our son has complex needs and currently has around 15 health professionals involved in his care. This doesn't include education, local authority or charity professionals. I'm sure you can imagine just how much admin is involved in managing his care needs, especially when you add in funding applications. I've had to give up work in part to manage this, and it can often be a stressful process. Whatever the situation, though, it's always a relief when I know my query needs to be sent to Karen. She is so efficient. There never needs to be any chasing. If something is taking a bit longer than expected, she'll always let me know. Having someone like this makes the world of difference. It may seem simple, but in reality, so few areas maintain good communication. By removing this stress from the areas she helps with, Karen has made a world of difference to our life. Karen, what a wonderful nomination. On behalf of that family and on behalf of the Trust, you are a very, very worthy winner of this month's Going the Extra Mile. And so thank you very, very much on behalf of the board.
Okay, it's very humbling. She's a lovely lady, and she has an awful lot on her plate. And to be honest, I don't feel that I've gone the extra mile. I feel that I've done what I'm getting paid for. And I think she went on to say that it's what it could be and what it should be. And she's quite right. It is what it should be. It's what we should all be doing, really. It's nothing outstanding. But, I'm grateful all the same. It was very kind of her.
Well, take the praise whilst it's being given, Karen.
Exactly, yeah.
Quite often you go through life without getting any praise.
You're quite right.
But you're absolutely right. But yeah, I think also what it emphasises is just in the little things we can make an enormous difference to individuals' lives, and you do that day in, day out. So thank you very much.
Oh, thank you.
Now, in terms of the Going the Extra Mile team winners, this is for the Urgent Response Team, place-based Team 7. Sounds like a 1980s series set in space, Place-Based Team 7. But I'm delighted that David at least is with us to hear the nomination. And so the person who nominated you said, I'm nominating this team to recognise the outstanding collaborative work and dedication given by an amazing team of nurses and physios in South Warwickshire. Urgent visits allocated for end-of-life patients for catheter issues. The example given is where you, David, was the first practitioner to arrive and was faced with a patient that needed above what he could offer on that visit alone. The patient was on a foam mattress and was lying in a repose cushion under his sacral area. I'm going to have to, I'll edit this a bit because it's a full Monty, this nomination. And Grant, glad you've joined us as well. While I was getting help for this patient, the Myton at home nurses arrived to carry out their assessment to take the patient in for personal care. Seeing the state the patient was in, and straight away gave personal care and cleaned the patient up, putting him on new sheets, etc. I made contact with the Warwick District nurses and reached out for a nurse or a clinical support worker to help get the patient onto his new mattress, but managed to release the nurse in charge, Sharon, who was amazing when she arrived. I then contacted Grant, who's dialing in from his phone. So Grant's obviously out in the field. So Grant, lovely to see you. Who at the drop of a hat came out with the manga cushion to help with the patient transfer onto his new mattress. This was such an amazing team effort at the drop of a hat to make sure I had help needed to get the patient the best care possible. So recognising the flexibility, compassionate and dedicated work of all staff they gave to that patient on that day. And I know that's just one example of what you all do as a team day in, day out. So for the UCR team, big round of applause. Thank you very much for all your hard work. Okay.
Thank you.
We greatly appreciate it. You have a great rest of your day. You're welcome to stay for the rest of the board, but we'll understand if you're unable. So thank you.
Thank you. Thank you very much for the nomination. But I'd like to say that everybody in the team, everybody and everyone we work with are just an amazing bunch of clinicians, and everyone pulls together when needed. So thank you for the award. It's very much appreciated, and the whole team is super chuffed that we've actually got the award. So thank you again very much.
Okay, well, one of the great
I do have to go.
No worries. But one of the great things about us being in a digital world is you don't then have to have your photograph taken with me, so you can Okay, so
all right, thank you for the meeting. I will have to go because we're super busy, but thank you again.
Okay.
Thank you. Bye.
Bye, David. And there's 3 ambulances on the way from Worcester to make David and the rest of the team even busier over the next few hours. So we have apologies for absence from Gertie, from Phil Gilbert and from Bhaskar. We've got Elva with us, who's deputising for Gertie. Any new declarations of interest? Could you please raise a digital hand if you have any new declarations of interest? Glenn, I could see you enthusiastically with your hand up earlier. Glenn?
Yeah, I should formally declare that I am now Chief Executive of Worcester Acute Hospitals, as they've joined the group with effect from the 1st of August.
Okay, absolutely. And I should equally brief on the fact that I'm now chair of Worcester Acute as well as the majority shareholder of a new company called Maranatha One Properties Limited, which has been put onto my declarations of interest. Before we move on, there's just one other thing I wanted to cover off, and it was with respect to some potential confusion over the process with associate non-executive directors and the process we've just gone through. So I just wanted to clarify a few things. So we have undertaken an interview process recently aiming to appoint 2 new associate NEDs, and a recommendation is being made from the Governor's Nominations and Remuneration Committee to the Council of Governors on the 21st of September, that we should in fact appoint 3 new associate NEDs due to the strong calibre of the candidates. This is in part as a succession plan for Sue Whelan-Tracy and Simon Page, who over the next couple of years come to the end of their terms of office. Subject to the Council of Governors approval and pre-employment checks, those candidates will commence on the 1st of October. And their names are Bharti Patel, Oliver Otter and Ollie Hisco. To ensure that all the board members are briefed, associate NEDs and NEDs in training are NEDs in training and are non-voting board members. An associate NED will move into a substantive non-executive position as and when vacancies arise, subject to a review of their performance by me. They hold office for an initial term of 3 years, which is the same as a normal NED, and subject to the same appointment processes as a NED. So I hope that clears up any potential confusion about the role of an associate NED. So we'll move on to the minutes of the meeting held, because the last time we were together was in July. The meeting held on the 5th of July. If there were any points of accuracy on those, could you please raise a digital hand? Okay, I can't see any digital hands. So we did have just a few actions arising from that meeting. The first was with respect to the digital health quarterly report. Adam to provide a copy of the digital hub strategy to Miss Sue Whelan-Tracy. That was done. Thank you, Adam. Then we had a question from a public governor, Harcomel, to contact the relevant public governor to explain the contractual pathway of the community eye service, and that has been done, Harcomel. Thank you very much. And then on the board assurance framework and risk quarterly report, Adam to ascertain that the risk level was appropriate for the increase in demand within the emergency department, and that's been reviewed and is also complete. Is that correct, Adam? Super, thank you very much. Our last meeting for members of the public who joined us was the 3 board foundation group meeting held on the 2nd of August. The minutes of that are also in the report. For this board, were there any points of accuracy that you would like amended? Could you please raise a digital hand if there were? I can't see any digital hands raised, so I'll take them as an accurate record. And shockingly, I don't think, oh sorry, page 27 of our pack, and there were a couple of action points arising out of that. The first was that the MDs of Jane Ives, Adam Carson and Catherine Free would ensure that analysis takes place to compare cancer diagnoses. That's ongoing and is going through the cancer boards, isn't it, Adam? Thank you.
That's correct, yes.
And then a deep dive into additional performance measures, particularly around theatre productivity. And Harcomel, you're taking that forward as well, yes? And the exciting thing for members of the public is that the next foundation group meeting will be all 4 boards and is being held at the start of November. Are there any matters arising that you feel I've missed? Okay, thank you. So I'll then move on to the chairman's remarks, which is now sort of a standing item, and I've put in that a briefing from the last integrated care partnership update, which I will take as read. Regarding things going on in the system, we have had a session, the SWFT NEDs, with other partner colleague NEDs run by the ICB, which was an interesting discussion. Just so members of the public are aware, what I am continually focusing on, though, is that any discussions on changes to clinical pathways should be evidence-based. And it's become quite popular to come out with positioning statements or views as to the way things should be arranged. At SWFT, I just want to ensure members of the public, We will only support any changes to clinical pathways where the evidence for improvements in patient outcomes or for a lower cost of delivery are very clear. There are quite a few discussions going on in the system at the moment as to the way things could develop, and we're actively involved in those, and our clinicians will be actively involved in those. But any decision that we made, members of the public can be assured, will only be done on the basis of evidence, because that ensures we make the best decisions. And the final thing on the chairman's remarks is, as Glenn has indicated, and I have under the declarations of interest, we are now chair and chief executive of Worcester Acute. That does come with its own challenges. Worcester Acute is self-evidently an organisation where its performance has some highlights and some really good practice. But overall, particularly on flow and ambulance stacks, is extremely problematic. Glenn is doing some absolutely sterling work in addressing those challenges, but the volume of challenges, I think, has exceeded what Glenn and I expected. So it isn't going to be something that's sorted in the short term. But what has become increasingly clear to me over the last 6 weeks since we've taken over is if Glenn and I had not got involved, the consequences on SWFT, and in particular our emergency department as we enter the winter, would have been extremely alarming. So the actions we have taken in terms of getting involved will hopefully minimise that impact. But it is taking a lot of work, and on behalf of the citizens of Warwickshire and Worcestershire, I want to thank Glenn for his very real commitment to everything that's best about the National Health Service. Thank you, Glenn. Any questions on what I've said? Okay, thank you. So we move on then to some items for approval. The first up is a winter plan and vaccination plan. So Harkema and Fiona, over to you.
Thank you. So Fiona and I have put together our winter vaccination plan for you. So I won't go through the whole thing, but there are a few bits that I wanted to just draw out. So NHS organisations were written to at the end of July to talk about what our operational resilience looks like over the winter period. So I've included like some sections from that letter within this, just to bring everyone's attention to our ambition. So you'll know that 76% is the target for the 4-hour standard in ED. So patients need to be seen and treated within 4 hours. And with the exception of August, we've been quite good at that this year. The incentive scheme, as I put in the letter, sets out an ambition to hit 80% over Q4. And then that will give organisations the opportunity to access a capital fund. And I'm sure you'll all agree that that's vital for us. So I've included that in the letter because that really is an ambition of ours. And we've all signed up to that as a board and certainly as an organisation, because it is an organisational standard, not just an ED standard. And our approach to winter, I think, really dovetails quite nicely into this. So in terms of the approach that we've taken, we've done quite a lot of lessons learned from last winter, but also just from the ongoing pressures that we've had. It was our busiest month was in the summer this year. So I'm almost minded to do a reflections from summer piece for board, because I think it's been a really interesting time in terms of some of the demand that we've seen, some of the pressures and the impact of weather, and the impact of industrial action, and all of the lessons that we've learnt from that are principles that we put forward into our winter plan. We've used a lot of our Excel in Everything framework as a way to map through some of our initiatives. So we have a programme that's called Front Door Redesign. So we're really trying to understand how we can best design our pathways to maximise the opportunity and make sure our patients are treated swiftly and as appropriately, and we can get the patients into the right place as quickly as possible. We're working with our PACE colleagues on what funding looks like and what we would do with that funding and reorganisation. And I've put some details of that in the paper, but really it spans across additional capacity, trying to use additional ambulance capacity, because we know that that's really supported us in getting our patients home as quickly as possible, trialling out additional pathways, and really having robust same-day emergency care So I've talked quite a lot about how important same day emergency care is, and we're trying really, really hard to make sure that we don't bed into that. And that they essentially are a summary of our schemes. We haven't had confirmation of funding just yet, but as soon as we do, I will make sure to include that in a pack so that there's transparency of what of where we're focusing our interventions. But really, our winter plan, as previous years, tries to focus on the whole thing. So what happens pre-hospital and what can we do to try and avoid people coming into hospital in the first place? And where's our what else can we do to try and help patients? Once they're here, can we stream them effectively? So making sure they get to the same day emergency care, if appropriate, or admitted into a bed as quickly as possible. Really robust processes once they're here, and then really strong processes to discharge patients and support them in and out of hospital setting. The other bit that I think I just wanted to verbally update everyone on is just the day-to-day battle rhythm of how we manage some of this. So winter is sort of, something we used to talk about years ago. It doesn't exist anymore. June was so busy in this organisation. The volume of patients turning up to our ED was just something we never would have expected to see on the winter on the Warwick site. It's just not been seen before. And then when we look at what that data looks like in terms of the reasons for admission versus like the length of stay, it's really a challenging picture throughout. And what we're really learning as an organisation is that absolutely we can have really, really bad days, but we can recover really well. And using all of that data to understand what went well and what didn't, and having conversations as quickly as possible in an MDT setting, I think is really key to that. So we have a daily meeting where we have executive officers, nursing and medical and management colleagues to understand what's happening in the organisation and to rapidly put in place plans to try and support the organisation. So that really is the ethos of our winter plan at SWFT, and certainly, well, our day-to-day plan, and certainly what will carry us through into the winter. And then Fiona, I just pass on to you for the vaccination plan.
Yes. Just before you move on to vaccinations, we'll just talk about the winter plan for just a second, if that's okay.
Yeah.
So any questions or perspectives to Harkamel on what we have read, seen and been briefed on the winter plan? Charles?
Yeah, I would just like to also mention how effective the operational team is, day in, day out, dealing with the pressures and recovering quickly when we get a peak. And that performance, we need to bear in mind, we are a preferred emergency service to a lot of people around us beyond our catchment area, and we receive a lot of intelligent conveyancing, as you alluded to, from other trusts. So whenever I'm involved in those flow conversations day to day, it's a very robust team who work very hard at every little piece of the pathway.
No, point very well made, Charles. Thank you. And Sue?
Yes, thank you, Harkamel. It does show in the paper how well the team is recovering after peaks, and also you're pretty good at predicting what will happen in these very unpredictable times. My question was around communication to the public, because there's quite a lot of changes to how people might expect to be treated within secondary care or in the community. I'm wondering whether there is a plan to clarify for winter what people might expect. Thank you.
Yeah, I'm really glad. Can I ask? So I'm really pleased that you asked that, because we actually discussed that today at our silver meeting. So we are trying to change the way that we, well, not change, just enhance the way that we manage the day-to-day and bring in data. So Wednesdays are our review of what happened last week and what can we predict to happen next week. So using the data to inform patients then on where else they might be able to get some support, or what might happen, in a protocolized way for, as you say, how they might be managed when they get here. So it's a combination of both, using the data to, so we know, for example, next week we're expecting storms. Last time that happened after a heat wave, we saw quite a surge in respiratory. So it's really important that patients understand, what those pathways look like, and if there's different places that patients can get support. So absolutely, we're using the data to try and inform that and involve our public and our patients in terms of some of those messages, so to get people into the right place, but also so that they understand what could happen when they get here.
Thank you. And Glenn, did you want to add something to that?
Yeah, I was just going to add the fact that been talking to the communication teams across the group about the home first philosophy that we have, and the need to help to inform the public that that's not about us not having the capacity to treat them. It's not about us not having the money to treat them. It's about the best care model for those individual patients, and families helping us to support to get particularly older frail patients home. So we're going to do a coordinated piece of work on that across the group.
And we talked about the community support response service this morning, which I think is helping again on flow. But I see an awful lot on social media, Harkamel, coming out from the comms team in terms of trying to direct patients. So well done. We'll move on then to vaccination update. Fiona?
Yeah, so our plan this year is similar to previous years. We aim to vaccinate 80% of our staff and offer it to everybody that wants it. We started planning back in July. We're going to be running a sort of hub and spoke system, as in a vaccine hub set up on site at Warwick, and then also at George Eliot, where our North community staff can access, and a team of peer vaccinators that will go out into clinical areas and vaccinate for flu. That will be COVID can't be transported, so they do need to go to the hub for that. We will take the opportunity while people are being offered their vaccine to do a welfare check, offer them a drink and a snack and a pen, and just let them pause from their busy time for 10 minutes while they have their vaccination and talk about their health and well-being. We've got a comms plan that's aligned to this in terms of ensuring that there's a frequently asked questions and there's myth busting around vaccinations. But just take the opportunity today at Public Board to encourage all our citizens, particularly the most vulnerable, to be vaccinated both for flu and COVID, as well as our healthcare workers.
Thank you, Fiona. Any questions to Fiona on the vaccination plan? So these, sorry, Pramjit.
Thank you very much, Fiona. Sounds great. It's I'm glad to hear that you're going to take stock after you've jabbed them. How are you feeling, and so on. But one thing that sort of struck out was it's good to give them water. Great. I'm thinking about our prevention strategy here. Now the snacks sort of raised its head here. I'm just in, what sort of snacks were you thinking of?
Take a break, take a Kit Kat, of course.
Oh.
We will consider healthy snacks if you'd like. Yes,
I think so. I think it's the right message, I think, to promote to all our staff, and also at the same time to encourage their family members to get vaccinated as well.
Yes, of course. Thank you.
Both points well made, Pramjit. Thank you. So these two items are both for approval, just each one in turn. The winter plan, if you're not happy to approve, please raise a digital hand. Can't see any digital hands, so duly approved. And secondly, the vaccination plan, if you're not happy to approve, please raise a digital hand. Duly approved as well. Thank you, team. So we move on then to the protecting and expanding our elected capacity self-certification, which is also for approval. Harkamel, back with you.
Thank you. So this would have linked if I'd have said it into the previous item, so I'll say it now. It absolutely is an ambition of the organisation to maintain elective operating throughout winter, as we have done in previous years. So I just wanted to make that clear that we're, that's definitely still the driving force behind us. With regard to this item, Acute Trust were written to set out the next steps in terms of outpatient recovery, and we were asked to provide assurance that we are driving outpatient recovery and undertake a board self-certification. And we decided to bring it to Public Board because actually outpatient recovery is an area that I'm really, really proud of, and it's really, really important to me. Outpatients is one of those areas where it can really make or break a patient journey. You hear some of your best news and some of your worst news in that setting, and actually we don't necessarily always talk about it in the same way as I perhaps do, like 4-hour standard in a public meeting. So I hope that's okay. I have put in the self-certification and provided the assurance for each item, so I won't go through that in detail, but I just wanted to set out that we are really trying our best to truly recover outpatients, not just in terms of our long waiters. I've talked before about some of our excellent progress against that, and that focus remains, but also considering the patient experience. What's that environment look like? What are those pathways like, and how we're involving our patients in some of this work. And we're really fortunate to be part of the GIRFT Going Further, Going Faster initiative. Where I feel really lucky that we were selected to be part of that, and with that comes quite a lot of intel, just in terms of different pathways, really good networking to try and learn from best practice from other areas. Also the opportunity to showcase some of the things that we're doing. And at a future board, I will present an update in terms of what our outpatient recovery looks like, so that we can have perhaps a bit more of a conversation, but that's why I've brought that here.
Super, thank you, very clear. And I understand we're one of Tim Briggs' favourites, so well done you. Questions or perspectives to Harkamel on this? Sue?
Yeah, thank you for bringing this to the board, Harkamel. It's really welcome to see set out so clearly all the initiatives, and I welcome the support from the centre as well on it. My question was around PIFU, so patient-initiated follow-up. Is quite a change for an increasing number of residents of Warwickshire, and that the role that they play in their care is changing. So I just wanted to check that patient engagement is in place within that PIFU project.
Yeah, so for a patient to move on to a patient-initiated follow-up, that's as part of a conversation with the patient, either in the consultation or via a letter. But the really important part is that if a patient is put onto a patient-initiated follow-up, that's a direct access then in to be able to reactivate a pathway that they may need to. And so it's an opportunity for us to have a bit more of an early indication in terms of should a patient want to see us or not. And in terms of how we decide who moves on to a PIFU, each specialty is going through quite a rigorous process with the clinicians to develop what the standard operating procedures should look like. And within that, there's a guidance for what the written and verbal communication should be, because it's really important that people understand what a PIFU is and how you then reactivate that. And certainly when, as part of our digital transformation, the letter templates are really, really important, and all of the different ways that we can consider to try and engage with our patients. But we're realigning all our letters and our patient guidance so that we can make sure that everyone is seeing that at the moment. The other thing that we're doing is, so we started this piece of work, but it is ongoing, really trying to understand the reactivation rate. So we had a conversation yesterday, actually, at our Further Faster meeting around what's the volume like in terms of reactivation. And actually, it's quite hard to see. As a pure figure now, I could say 18.8%. But then I would hope that you would say, well, when did they get put on PIFU? Was it a year ago? Was it 6 months ago? Like, how do you know 18.8% of what? And so one of the things that we're doing as part of our outpatient transformation board is to look at this, to look at which specialty is it, what if we've got, so at the moment, for example, it looks like we've got a 40% reactivation rate in physio, but actually that might be appropriate, that might be what we expect to see, or it might be that data then tells us that we need to configure our clinics in a slightly different way. So in answer to your question, patients are absolutely part of that journey. And we're doing everything we can to make sure that they understand it and have a way to feedback, but also we're putting in safeguards behind the scenes to make sure that we're catching things in terms of if the data is telling us that it doesn't feel quite right, or the reactivation rates are telling us something else, we'll then do something different.
Super, thank you, Harkamel, very comprehensive. So we also need to approve this, team. So if you're not happy to approve this, could you please raise a digital hand? Duly approved, Harkamel, and good luck. So we'll move on then to the Chief Executive's report. Glenn, over to you.
Thank you, Russell. Sadly, this month I start with the conviction of neonatal nurse Lucy Letby. I won't read out all the elements of what I've included here, but this is obviously something we'll spend quite a bit of time on as a board, just reflecting on the learning from that and whether there's any improvements we can make to our own processes. I think it's really important that this isn't seen as something that's happened in another organisation or just in a neonatal service. This is, sadly, you could have a situation where any trust in any specialty could employ someone like this. So you need to have the right safeguards in place to spot, either through data or through the speaking up culture, of the organisation that these things are going to be addressed. So I know we'll touch on this a little bit later on in the meeting when we get feedback from clinical governance chair, and I'm sure as the NHS looks at learning from this, we'll bring this back to future board meetings. I then turned to quite a lot of content which Harkamal's already kind of covered off there for us. I attended the NHS Recovery Summit in July, which was another really good opportunity to take stock of how the NHS is doing against the recovery milestones that we've set, and that followed on from the session we had in January. And encouragingly, following that, we did manage to get a winter letter out across the NHS by the end of July, which is a bit of a first, and that's what's led to some of the assurance processes that you've been looking at here. In my final paragraph on that page, actually, I refer to, I have the words regional and passion in the same sentence, which is a typo, because I've never seen them together in the same sentence before. It should say the regional position. So the regional position on elective recovery is has improved a lot over the last few months. Our own position is encouraging also, and obviously you may hear some sound in the background as our elective hub is being built behind us. We will continue to be not only improving our own elective waiting times, but also helping some of the other organisations around us. And these two are intrinsically linked. So the way we manage elective recovery, but also the way we manage urgent care is so important. So that assurance process of protecting and building our elective our elective capacity is really important part of that process. And I think we are seen as absolutely best practice in this. And Harkamal was talking about this in front of Tim Briggs, hanging on her every word yesterday as we talked about how we have a culture of protecting our elective work, and that's allowed us to have very good results for our patients, very high levels of productivity. Within the winter planning letter this time, I think one thing that I like about it is that it's tried to get the balance right between the system level accountability, but also the accountability at individual organisations. And so there's a job card for each part of the system, including mental health services, children, young people, but also for acute and specialist trusts and community services. And I've just included those there so you can see the kind of best practice that we're being asked to ensure that we have in our plans, which we certainly have in ours. And I won't go through all of that. There's probably a bit more than you would have liked in my report, but it's there. I also refer to the capital incentive on UVC recovery. As Harkamal said, we aim to go for that for two reasons. Firstly, because it would be good to access some additional capital, because there's always something we want to do. But secondly, improving access for our patients delivers better outcomes for our patients. So there's two very good reasons why we want to do that. And it's looking at those two indicators of the ambulance handover 30-minute timeline and the A&E performance within the 4-hour standard. And we'll be aiming to try and beat those milestones. I then do a piece on the workforce plan, which is there for people to look through. I won't go through it all. There's then an update from the system, including the letter following the latest system review meeting. And just to praise our colleagues, Foundation Group colleagues at George Eliot, that they've managed to move from segment 3 to segment 2 in the single operating framework. SWFT is still at 1, so testimony to our teams who are still there. As a result of SWFT and George Eliot being in that position, the whole system has moved from segment 3 to segment 2 now. And the other two trusts, UHW and Coventry Partnership Trust, are in segment 3. So it's good to see our organisations bringing the whole system segmentation up. There's then an explanation which has been provided by Sarah. Thank you, Sarah, on the fit and proper persons test framework, which has been recently reintroduced. An update on the health visiting service section 75. Words about our EPR, which we will be spending quite a bit of board time on, and we spent some time on again this morning in workshop. We have now signed a memorandum of understanding with University Hospitals, Coventry, Warwickshire and George Eliot around the implementation of our new EPR, and that will ensure that we have a single instance across the 3 acutes in our system, which will help us with patient flow, but also help us with the way that our workforce works across the system. And then there's a specific report back on our ophthalmology team, reminding us about the complexity of ophthalmology as a specialty, actually, and the amount of our waiting list that is related to that particular specialty. It's the largest outpatient specialty in the NHS, and there's quite a lot of innovation going on there within that team, particularly the development of nurse practitioners and some of the research they're involved in. And then finally, at the end, there's the normal list of visits to wards and departments from execs and non-execs. Happy to take any questions, Chair.
Thank you, Glenn. Any questions to Glenn on his report? Please raise a digital hand. I think just so members of the public are aware, a lot of the non-execs pop in an unscheduled way to do hospital visits, which aren't on that list, so it isn't fully comprehensive. Okay, we'll move on then to the integrated performance report. And Adam, what would you care to start to pull out?
Thank you, Chair. I feel like I say this every month, but it was an incredibly busy July again. Having said that, there was some relief, particularly in emergency department numbers from the record-breaking attendances we saw in May and June. Despite being very busy, we've had some good performance across the majority of our areas, and I particularly want to highlight our community urgent response services, the continued meeting and exceeding of ED national targets, and the positive elective activity work that we have already discussed today. And we need to set this in context, of course, not only against the demand on services, but the industrial action. And I think in terms of industrial action, I just want to commend the flexibility of all of our teams for supporting during the strike periods. As a result, we've been able to minimise the amount of cancellations of elective activity, although I think it's fair to say through October and through August and across the summer, that got much more difficult as we contended with staff leave, summer holidays and so forth. So we will see more effect of that in the August figures, but it really has been great to see the way teams have pulled together, and thanks to my executive colleagues for all the planning that's gone into that. In terms of cancer, there's a mixed picture. Now, Harkamel has done a deep dive as part of her report, so I don't want to steal too much of her thunder. But in summary, we've had positive progress on our 28-day faster diagnosis standard performance, but we're still seeing inconsistent performance on the 60-day referral to treatment standard. One of the most significant challenges we have there is the time to the first oncology appointment, and obviously oncologists are provided by University Hospitals Coventry and Warwickshire at the moment. So we are working with them on the model there, and indeed have met the ICB this week to discuss that. And I'm sure Harkamel will say more as part of her report. Patient feedback is incredibly important to us, and Fiona will talk a bit more about that as part of the patient experience report, which is on the agenda today. But I think one really important thing I wanted to highlight here was that we've introduced a new feedback points system, which we initially trialled in ED. And from that, we've seen a significant increase in the amount of feedback we've received, about fourfold increase, which is really positive. Any feedback is good feedback and feedback we need to reflect on. But I think the fact that the majority of that feedback is positive shows the great work our teams are doing despite the demand pressures and capacity challenges we know we have. I just want to end on finances. So month 4 showed a deficit of 2.14 million against plan, and that is mainly driven by non-delivery of our CPIP targets, but we're also seeing an effect from the industrial action. This remains a significant area of concern for me, although it's fair to say we've had some progress in the last month as we've seen delivery of CPIP schemes ramp up. We had a good presentation at the board workshop session this morning about the long-term workforce plan and some of our own workforce indicators, and it's clear we've seen a reduction in sickness, a reduction in turnover, and increases in our time to hire. We have seen during August a reduction in agency nursing staff spend, which will help, although there are still challenges with medical agency spend, which we are working through. All of this is obviously affecting that overspend, and we do have plans to bring it back in line, and we are still predicting a break-even position at the end of the year, but there are clear challenges there we're working on. I think that's all I wanted to say in summary, but my colleagues will no doubt expand on those points in more detail.
No, that's great. Thanks, Adam. Colleagues, happy to move into the detail? So we'll start off then with quality and safety. Fiona, do you want to lead, and then Charles follow?
Yeah, I'm happy to. I was just going to put out two things, and one of them was that patient experience. And so just following on really from what Adam says, we have had that increase in feedback, and 95% of it is positive, which is a really high number and shouldn't be underestimated in terms of the experience our patients are having. What the other was just right at the bottom of my my report was around infection prevention. As we go into winter and we've seen an increase in flu and COVID cases, it's really important to get assurance around our IPC, our infection prevention and control measures. And it's really good to see that our C. diff figures have not increased any further since the summer. The public will remember that we reported a flurry of cases of C. diff in the summer, and we were concerned that we were off target in terms of our threshold, and were worried, and we did a significant piece of improvement work, and we've had no further cases of C. diff. And now, actually, don't want to tempt fate, but we're in the best performer in the region of an acute hospital for C. diff numbers. So we've completely turned that round, and that's thanks and praise to our teams and the efforts that they've done on that. They were just the two that I wanted to pull out of my report. Thank you.
Thank you, Fiona. And Charles, anything you'd like to add on quality and safety?
Well, apart from the mortality, which will we come to that? Or would you like me to talk to that now?
Well, why don't you talk to it now, Charles?
Yeah. So the mortality indicators remain actually stable and in control limits. We have seen an improvement in the SHIMI, which is the important nationally validated measure, and that only goes up till February. And we put in quite a lot of measures to cause further improvement, which really only came in April. So I would hope to see a further trend in the right direction, but it's stable. And just on the C. diff point, a lot of the improvement is really down to judicious use of antibiotics and antibiotic stewardship. And I think there's a message for the public there that sometimes people think antibiotics are the solution to all sorts of problems, and please take your doctor's advice, because it's well evidence based. And there are adverse consequences.
Well said. Thank you, Charles. Any questions to Fiona or Charles? We had a long session on agency controls as well this morning, didn't we? So thank you for your hard work, Fiona and Ellie, on that. We'll move on then to the operational performance. Kamal.
Thank you. So happy to take most of it as read, because I don't want to repeat what Adam said, but it was just to highlight that this was a really, really busy summer from an emergency demand perspective. And certainly, we used to talk about perhaps some periods of respite when you might be able to do some deep cleans and downtime when people are all on leave. We really have not seen that this year. But it does go to our winter planning, and I think it demonstrates that the increasing resilience of the organisation. And we did achieve the 76% standard for July, which I'm really pleased about. And although our ambulance attendances went up, actually one of the highest number of attendances in the year, we only had 3 ambulances that waited over an hour. And only 4.7% of our handovers were over 30 minutes. And as I alluded to in my previous report, the proportion of patients on an ambulance over 30 minutes is going to be a really key standard for us. And I'm really proud of the team for the interventions that they've made to improve that performance, because it is absolutely not the right thing for patients to be on an ambulance for longer than they need to be. Our attendances from Birmingham and Solihull have dropped. So you'll remember a few months ago I was talking about out-of-area referrals and the impact that that was having on us. And so in July we did see the attendances drop back slightly. And it is a reduction on June, and that's just something that we'll keep an eye on. I've included some stuff around our elective activity and what those values look like in May in terms of compared to 2019. But just to pick up on Adam's point, managing the industrial action over the next few months, I think is going to be really challenging because it's going to be both sets of doctors potentially off at the same time, and whereby we do attempt to not cancel. We were very careful with our scheduling in August, because the worst thing to do is to schedule someone when there's a chance of cancelling them with, you know, and having to cancel at the last minute. So we were really clear to our patients when we were booking them that we might have to take that activity down or convert it to something else. And whilst that took a lot longer, I'm really grateful to our bookers to take that time to spend with the patients during the previous industrial action. And then cancer performance. So I've included a deep dive into cancer performance at the trust, and I talk quite a lot about what our 2-week wait referrals look like, and it is increasing. So after I'd submitted the report, I had the August referrals in, and August was our second highest month ever for 2-week wait referrals, which is really unusual for an August. You know, you just do not expect to see that. September, you obviously expect to see the skin patients coming in after being on holiday, but to see that in August, I think is quite concerning, and certainly something that we'll keep an eye on. I've talked before about the conversion rate, and whilst that has steadied off now, so we're not seeing those peaks in conversion, it's not a massive drop either. So that does suggest that these are the appropriate patients, and that's really important, because if you think about those patients who are have come from their GP in June, in July, and then August, once they're then getting through their diagnostic pathway, they're getting through their operating, then they need to have, you know, access to chemotherapy or radiotherapy. I've included on my report my concerns around access to oncology. So I've talked before about some of the delays that patients face, and whilst that is significantly improved upon the position that we saw earlier this year, there are still long waits for some of our patients accessing specifically like breast oncology appointments for their first appointment. So these patients will have met their surgeon and either had their surgery or be a candidate who can't have surgery or should have surgery afterwards, and then need to go straight to chemotherapy. So you need the appointment with the oncologist in order to access either chemo or radio, or to be able to make an informed decision about what you want to do. So building that, having that delay within the system is really concerning. I've got lots of support from my executive colleagues, and we're meeting regularly with our system partners and with UXW to see what we can do to try and even out some of this waiting list. But I wanted to just bring that to everybody's attention in terms of one of my key concerns. And that's it from me. So
thank you, Harkamel. Very clear, and thank you very much for your hard work. Questions or perspectives to Harkamel? How disruptive do you think the combination of the junior doctors and consultant strikes will be in the start of October and September?
We're really worried about it. So in terms of the last sets of industrial action, we're quite good at learning how to do things. So, you know, I talked about our recovery. It's the same with industrial action. We get our back rhythm quite quickly, and we know what to do. My worry with the next set of industrial action is you don't just plan for the days themselves. You know, you plan for the days before so that you can make sure that flow is as good as it can be, and absolutely every patient has had a senior review, so you know what you can do. And then it's the battle rhythm as usual during the strike, and then the recovery is really important post-strike. But it works effectively because you've got other, you know, the juniors supporting when it's consultant strike and vice versa. Not to mention the ACPs. We absolutely could not do any of this without our nurse colleagues, but I am really concerned about the impact that it's going to have on my ability to maintain electives and to maintain good flow over the next few months.
Okay, thank you, Harkamel. We just have to hope that a resolution is found. And Glenn, then we'll move on.
Yeah, I don't know if this is a question for Harkamel or for Charles, actually, but one of the things that concerns me a little bit as we put in place more of our same-day emergency care access capacity is that could lead to patients using that as a fast-track outpatient route. And I suppose I worry, just looking at the demand levels of that might be what's happening. How do we ensure that patients are put onto a suitable pathway if they can wait, if they're not necessary for same-day emergency care? What safeguards have we got to learn from that, so we don't end up creating just everything going through a fast track SDEC?
Charles, do you want to come in, or shall I?
Well, I can start and then you can carry on. I think once the patient has actually arrived here, that we have to assess them, we have to triage them and assess them. If you look at the front door of ED, then we want to stream things to primary care if they're primary care, and primary care will in turn, if they can, send them back to their GP if it really isn't a thing for the hospital. But once a patient's actually got into an SDEC or got onto our site, we're duty bound to make an assessment, and it's very difficult to then not at least start to deal with the problem. I mean, clearly if it's not really urgent, then we will carry on the pathway as an outpatient, etc. But I think it's a problem, as you allude to it, and we also, I think, attract work because our ED is actually functioning better than many, and patients get a good service. There was a survey recently where approximately 20% of people turned up could have been treated somewhere else nearer to their homes.
And Harkema, anything you'd like to add?
Yeah, so I put it in my winter report, the bit about streaming. So, as Charles says, we do have GPs down at the front door, so it's really vital that we stream those patients off. But as Charles says, we can't prevent it. So one of the pieces of work that we've just looked at, and we need to interrogate this data further, is to try and understand how many of our patients have come to ED and have a place on a waiting list already and are perhaps just waiting too long. So that doesn't help me with the patients who haven't yet got their referral, but it does give a bit of an indication as to what's happening in terms of the experience of patients waiting, because it's, whilst it might be seen as the easy way out to come to ED, it certainly isn't easy when you're sitting down there or in your own pain and you're worried. So one of the things that I'm trying to do is understand from the data if there are any pockets, because then you can extrapolate back potentially, can't you? And then working with primary care colleagues on what else we can do to try and manage that cohort of patients better.
Okay, thank you, Harkema. Thank you, Glenn. Thank you, Charles. We're running a few minutes behind now, team, so if we can pick up, I've got an awful lot to cover. So, Elvin, Gertie's absence, what would you like to pull out in terms of workforce?
Yeah, I'll keep it brief. So Adam has already kind of alluded to the reduced sickness absence and turnover, and it is great to see that it's reducing month on month. And with regards to the turnover, we're now in the 9th consecutive month that this has reduced. So it's real credit to the teams in order to be able to support staff in terms of sickness absence and retaining staff, the clinical retention group, and all the work that the team are doing around flexible working and keeping staff in work, especially with the itchy feet clinics that we've recently implemented. And just one other thing really is to show in terms of the number of applications to the trust. So you'll see on the last second but last slide that we've really seeing a influx of applications coming into the trust. If you compare that to last year, it's nearly doubled. So that's really showing that the attraction to apply to SWFT is there, and we are seeing a lot more applications coming through, which is a really positive take home message. And in return, we are seeing a reduction in our vacancy percentage. But again, there's a lot more work to be done, but it's just a really positive picture this month.
Thank you very much, Elva. Long may continue. Any questions or perspectives to Elva? Glenn?
Just a really quick question on that. That table was really interesting. The thing that struck me a little bit though was the ratio of applicants who attend for interview compared to those shortlisted. It's only about 40%, which seemed a bit of a concern that with 4,300 nearly applications that we've got such a dropout rate. Is that a concern for you?
So I think it's the way in which that recruitment dashboard is put together. It's the number of applications that's received within that month, but the advert could have not closed, or it could have closed after that month or before the month. So it will only show then a certain number of applications shortlisted that have fallen within that month. So I think it's probably something we could take away in terms of showing the actual figures. It's just the way in which it's represented on that dashboard.
Okay, great. I think I understand that answer, Elva. Thank you. Okay, we'll move on then to the money. Lots of headwinds, Kim. Lots to be done. What would you care to pull out?
So, as Adam reported earlier, we're showing a deficit for the month 4 period, year to date month 4 of £2.14 million, mainly driven by the sort of slippage really in terms of the CIP delivery, as well as continued agency spend. We heard, earlier in the workshop session, really the detailed work that the medical and nursing reduction agency reduction boards have been working on, and you've also heard the update from Elva as well in terms of what we're doing around the workforce, and you can see the improvement in terms of our reduction in terms of our vacancy, improvement in terms of sickness. But we're only just, I think, early indications for the the August figures are showing that there are improvements in terms of the agency spent. So we're only starting to see the reduction in cash terms, I suppose, coming out more recently. So the challenge is actually just making sure that those continue to drive out really in terms of that reduction of agency expenditure. We've identified about 92% now of our CPIP target, which is great news in terms of identification, and the challenge now is turning those identified schemes into reality and cashable savings into this year, and also recurrency is the challenge for the organisation, and that's obviously linked into our Excel and Everything programme. So we've got a bit more of a detailed discussion in the confidential session around some of the further mitigations that we need to undertake, written out to all the divisions around making sure that they've got clear action plans in place, so that we can go through those in F&P at the end of the month, so that we're really clear around what they're doing in terms of tackling some areas where they're overspends, as well as slippage in terms of CIP, to ensure that they're back on track, so that we can support the divisions, particularly through this challenging period. The industrial actions is obviously a risk. There's a lack of clarity from the centre around how they're going to continue to fund the cost of any industrial action. So that's something for us to be mindful of as well, moving forward into the next period. So those are the highlights I just wanted to bring out. Thank you, Russell.
Thank you, Kim. Any questions or perspectives to Kim? Kim, you have a great team behind you, as you know, so can you particularly sort of have a shout out to Ravi and the rest of the team for the work they put in, week out, to try and help. Okay, Tim, we'll move on then, and if I can ask our colleagues, because we do have a lot still to cover, to be as focused as possible. We're first up with the quarterly safe staffing report. Fiona.
Yeah, thanks, Chair. This is our normal quarterly update on safe staffing. The position is a good one. We've heard that through the finance and workforce data that we've already heard, that recruitment, retention, vacancy position, agency usage is all improving. There are some hotspots in here in terms of ongoing vacancies, and particularly pharmacy and health visiting in Coventry and Warwickshire. The health visiting teams are being encouraged to learn from the Solihull health visiting team that have done a very good job on reducing their vacancy position. So I think some of that is in their gift, but we have also set up a specific pharmacy people board to support their position. So happy to take questions.
No, great, thank you. And the George Eliot board yesterday, Glenn and I got a lot of us showing some Samara about the Warwickshire North and South Warwickshire sustainability of pharmacy services. questions or perspectives to Fiona? Okay, thank you, Fiona. So we'll move on then to Lorraine, and I just want to re-emphasise something I did mention earlier. It is a very difficult time for all of our maternity and midwifery team, and I am incredibly proud of our team at Warwick. We were recently ranked by CQC as outstanding for leadership, and Lorraine, that's partly down to your endeavours, but the week in, week out endeavours of all the team that are in SWFT. So please do pass on the board's thanks to all of them. But in the terrible news we've had over the last few weeks about the Letby case, can you just give us your maternity governance Q1 report, please?
Thank you, Chair. So this is the Q1 report that covers April to June 23, and as you said, Chair, we were really pleased to be rated as outstanding for well-led and good for safe care by the CQC. We also had a very busy time because we also had an inspection from the NHS England and the Integrated Care Board to look at our compliance with Ockenden, and they also agreed that we were on track and continue to work on those actions. But it is down to the amazing team that we've got that we've been able to achieve that, but we don't rest on our laurels and we continue to strive to improve. As we know, CNST Year 5 and Saving Babies Live version 3 were also released in Q1, so we're busy reviewing what those changes are and making sure that we've got action plans in place to make sure that we align our compliance. We've maintained one-to-one care at 100% during Q1. Our births still remain high, so as the national picture looks at births going down at SWFT, they're not. We're also noting an increase in our area booking, so we're just monitoring that very closely. We've maintained our midwife to birth ratio between 1 to 24 and up to 1 to 26, with a busy month in July, as you can see on the dashboard. Really pleasing that our vacancy rates with midwives was 0 in June, but again, continue to monitor that very closely. Our COO monitoring compliance has improved, as well as our postnatal readmissions for babies from the introduction of a day 3 wait on our dashboard, which is really pleasing to see. Our area of concern is around our PPH rates, and we continue to monitor those very closely, and we've done a very deep dive into those and looking at key themes, and we review every PPH. So although it's still above the national KPI, it is maintained and static, and that is reassuring to see, and we're just doing further work which will bring back in Q2. We've had no new cases under our perinatal mortality review process, and we've just got 1 case with HSIB. We've had no stillbirths in Q1, and our rolling weight rate is 1.3 per 1,000 births, which is below the national average. And we've had 1 neonatal death, sadly, in the quarter, which our rolling rate is 0.9 per 1,000 births, which is below the average of 1.5. But obviously, our thoughts go out to the family involved and the staff involved in that. As we've discussed, obviously, it's been shocking news that we've had in August around the Lucy Letby awful crimes, and our thoughts go out to those families involved. We've put initial support straight in for our staff, so we've had debrief sessions, we've written to our staff and our families offering support. I think the really important thing to note, and I think that's been mentioned before, that actually a lot of the concerns are around freedom to speak up, and that's not just about maternity and neonates, that's across the NHS. So again, we are reassuring all our staff that they must, if they can speak up, we use our freedom to speak up guardians, ambassadors, our PMAs, our attention leads, or speak to their line managers, but it's really important that staff and families feel able to share their concerns. We have really robust processes to review our mortality and rates of governance, but we will bring a report back for the board next month just to assure you on all the process that we have in place to make sure that we're very much aware of all of our data. Happy to take any questions, Chair.
No, that's great. And just before we move off that, so and this is for members of the public, Charles was talking earlier on about SHIMI and the way we look at mortality generally. Just for the avoidance of doubt, we do look at baby mortality differently. It's an immediate alert that goes out, isn't it, on baby mortality. So when you compare it to Letby, and Sue Pike is on the agenda for later, there weren't any freedom to speak up guardians when Sue Pike was doing these evil crimes. But equally, the way we look at deaths at SWFT is, and nowadays in maternity units, is if there's a single death, it goes up across the organisation very quickly. Any questions to Lorraine? Okay, Lorraine, thank you.
Thank you.
So we will move on then to the patient experience quarterly report, and Fiona, back with you.
Thank you, Chair. Just to pull out, this is again our quarterly report on patient experience. It covers all of the feedback that we get, both positive and negative, through into the corporate patient experience team, which includes the bereavement PALS and complaints team. Obviously, we collect individual verbal feedback from patients across our services all the time, but these are the more formal processes. Pleased to say that our complaints compared to our and negative feedback compared to our patient contacted remains low as a percentage, but we endeavour to investigate everyone and learn from those. Some of the lessons learned and the themes of those are contained within the report. I want to, as I said earlier, we've in month improved our processes around gaining feedback through what used to be called friends and family test. Using a different system, we're getting a much better feedback response rate. Finally, new in this report is the percentage of complaints, formal complaints, that are being responded to within our agreed time frame, and that is the area of focus now in terms of our improvement. Partly due to the demands on our service, partly due to other priorities, that response rate has become lower than we would want, and so we are across the organisation within the divisions focusing our time and effort on improving that performance and making sure that our response to complaints is timely and what we would expect for our families if they had taken the time to write to us. We'll continue to show that progress in this report on an ongoing basis.
Thank you, Fiona. We know we don't get everything right. We know on occasion that things go wrong, but I think it's a very assuring report. Any questions or perspectives, Fiona, on the patient experience quarterly report? Thank you, Fiona. So we then move on to the Excel in everything. That's a mantra. That's a mantra my wife gives me when it comes to DIY. Excel in everything, and on the DIY front, uniformly fail in everything. But on the Excel in everything programme, Sarah.
Thank you, Chair. I'll try to follow that. Actually, I'm mindful of time, but also that we've heard an awful lot about the Excel programme during the meeting, and already from some of my colleagues, and actually that is music to my ears, because that's exactly what we wanted to achieve from this programme, a programme which cuts across all portfolios and feeds into our objectives and trust strategy, and hence the name, as you point out, Excel in Everything. So in terms of a few quick highlights from me, Kim's already outlined the savings. Within that, there are 3 divisions that are on or ahead of their savings plans and 3 divisions which are behind plans. But across all the work streams, we're seeing some absolutely brilliant quality and operational progress, some of which you've heard examples of already during the meeting. And I think one of the things that pleases us as a team the most is that we continue to see colleagues coming forward with more impressive additional ideas. There are more PDSA cycles taking place, and we've now got over 130 active projects, with more colleagues getting involved in those projects. And so as a team, we believe that is having a really positive impact on enabling us as an organisation to maximise and expedite delivery, but also on our improvement culture. So Holcombe's shared quite a bit about the outpatient transformation programme already, but in terms of a shout out to outpatients from me, I think they should be really proud of the standards that they've developed and just launched. And you'll note from the report that we benchmark very well now for our new to follow-up ratios and also our DNA rates. And both of those metrics continue to improve month on month. So happy to take any questions.
Super, Sarah. And again, just thank you for your leadership at the Excelling Everything programme. We wouldn't have achieved what we have done without you leading it. Thank you. Questions and perspectives to Sarah, Glenn?
Just to add, Russell, and Harkamel touched on this earlier, we will, when we have our next board meeting, we'll be taking a bit of a look at outpatient transformation work across the group. So we've got an opportunity to share some of this and to see what else is going on elsewhere in the group we could learn from.
Absolutely. Thank you, Glenn. We'll move on then and invite Sue. Sue, freedom to speak up, as I said, unbelievably important generally. And you do a super job with Deeper over in the George Eliot, I know. We've got our Freedom to Speak Up conference coming up, which we're looking forward to. But what would you care to update us on now?
I think if we take the report as read, and just pick up some of the comments that have already come out through the meeting about Lucy Letby. And as Russell, you rightly said, there wasn't a guardian role at the time that those crimes were being committed. And I would like to think that now in our organisation, if anything like that was to happen, there are additional routes for speaking up, which would have no doubt helped at the time. I know there's a lot of concerns around speaking up and the independence of guardians. Deeper and I spoke, because I know you had this at George Eliot Board yesterday, about whether the guardian role should be independent or whether it should be employed by a trust. And to give colleagues and guests on the call assurance, I think from our perspective, being employed is really important because it gives us access to all of the things like Datex. We can triangulate the data much better. So if we have a concern come into us, we can immediately make contact with you guys as executives, but also our general managers, our lower level managers within the organisation to filter information, look for themes and trends, and to put more meat on the bones, which is really, really valuable. And I don't think you get that when you're an independently employed guardian. However, where we have needed to have external assurance or an external person involved, and I think the report talks about this in the ED case, we do invest in an internal person to come and do an investigation. At George Eliot, rather than SWFT, we have had an external guardian come and talk to our staff where we knew there were concerns about our impartiality as employed guardians. So we can have external support and we have accessed that in the past. So I think that's a good safeguard for us. And I think the other thing to talk about is the training. So it's really, really important that all levels of the organisation know how to speak up. But more importantly, that managers at all levels, so that's your supervisors, your team leaders, as well as you guys as senior leaders, know that they're listening to a speak up case and they treat it as such. So one of the big things that we're still not quite closing the loop on is feedback when people do speak up. You'll have seen in ePools today, there was a piece about feeding back from Datexes. So when staff contact us, they often have already raised a concern through Datex or through another route, and they just haven't had that feedback completed. And that's one of the things that then we can go and ask for. And sometimes that's because feedback is about an individual or it's confidential, but we just need to be better at closing that loop, I think. So that's probably all I'd say today, unless there's any questions or specifics from the report.
No, thank you, Sue. Just before I invite questions, I just really want to emphasise to any colleagues who are either on the line or listen to this in the future. Being open, being transparent is absolutely essential to have an effective, safe culture. And I would encourage you to use a rumour mill if for some reason you're concerned about using freedom to speak up. You're very welcome to write to me, to email me, if you've got any concerns about anything which you don't feel can be handled differently. The freedom to speak up and an open, transparent culture where people don't feel intimidated, don't feel anxious about talking about things that they are anxious about, is the cornerstone of the effectiveness of us as an organisation going forwards. Glenn, anything you'd like to add?
Yeah, we touched a little bit on this yesterday at the George Eliot board. This, should freedom to speak up be external? There's a lot of external routes that people can use, including CQC, GMC, NMC, lots of places that people can go to. But one of the things that's great about the way that you work as our freedom to speak up guardian is that there's that level of trust that our staff feel that they can talk to you. It has to be someone that is approachable, and also someone who knows the organisation. And I find the sessions that we have invaluable in giving me insight and Adam and others into the things that are going on in the organisation we've got a chance to do something about before they become big issues. So some of that low level stuff is really important. So I really value having that inside the organisation. So there's lots of other external routes that people can take.
Thank you, Glenn. And Sue, and then we'll move on.
Yeah, hi Sue, thank you for your report. I just wanted to add, as Freedom to Speak Up non-exec champion, that we do discuss, you and I, the internal versus independent on matters, whilst keeping things suitably confidential. And also I wanted to point out two things from your report. One, as you've said, it's really important that we do close the loop with staff about what's happened. And I was pleased to see you, as ever, showing leadership in that, in terms of your commentary around ED and the work that's gone on there and the areas that we can expect to see tracking and change. And secondly, just to say the trust has always very much welcome the volume and encourage the volume of speaking up. And I was particularly pleased to see that in the distribution of roles speaking up, that we have got some medics and consultants now using your route. So well done, and absolutely keep up the good work.
Yeah. Okay, I think there's a comment posted from a colleague regarding are people, patients and staff really aware of what external routes that are available. I think anyone who's employed by the NHS certainly know about CQC as a route to speak up, as well as their different Royal Colleges, depending on what their role is. So thank you. We'll move on then. Sue, thanks for your hard work. Looking forward to seeing you at the conference. To the Digital Health Board quarterly report. We're running about 20 minutes late, guys, so if we can pick up the pace. Adam, over to you.
Thanks. Just a few points to draw out, I think. To note, much of our work is focused on the EPR implementation and the preparations for that, which will commence earlier in the new year, and that will mean a ramping down of some of the other work we're doing. I do want to highlight some of the good system work we're doing now. Our teams in Innovate are supporting Myton Hospice with the implementation of the EMIS system, which is great news because it means we will have EMIS across community, primary care and hospices in Warwickshire. And I think the benefits of that integrated working are really clear. Also, we went live with a new trust extranet system over the last few weeks, which is brilliant. It's a much better system, much more intuitive, and fantastic work by our technical and comms teams actually in getting that up and running. Finally, I would note that on top of the disruption we've got on site for the elective hub build, people will have noticed cables and drilling and all sorts of other activity going on in relation to the builds of our new data centres. Really important, number one, because existing data centres are in the way of the elective hub build. But number two, it will help future-proof our technical estate for the future. And I know a huge amount of work is going into that. So well done, and thank you to all involved. That's all I wanted to highlight today. Thank you, Chair.
Thanks, Adam. We did have an update from Dan on the EPR programme. And it is encouraging that UHCW have signed a memorandum of understanding of how we work together with Cerner. But it is absolutely essential that we get access into those management and planning meetings at UHCW in the way we've given them access to our management and planning meetings over the last year. Because this is a project which can revolutionise the productivity of the acutes across Coventry and Warwickshire, but only if they work together on the solutions. And at the moment, we need access to those meetings to really do that. Thank you, Adam. Any questions to Adam? Okay, thank you. The Green Plan update, we did discuss the opportunities we've got in this earlier again in the board workshop. But Sophie, what would you care to pull out of this report?
Thank you. So hopefully the report is very assuring for the board at the progress we're making on delivering the Green Plan in all areas. I just wanted to pick up one highlight and address the 2 red areas in there. So the first highlight is that Charles and I are judging the Green Awards next week. And actually what's really pleasing, it's actually 6 clinical teams that have come forward to do that. We're working with an external partner on that, and they themselves have expressed that's unusual. So I think it just demonstrates we have got a lot of staff that want to be involved in helping us deliver this plan. So you'll all be invited to that presentation once we decide the winner. In terms of the 2 red areas, I do need to address these because these are the 2 areas we still need to move forward on. The travel and transport one, we're working with Kim about whether we can get someone that manages the contract for our for Noel's car lease scheme to help us lead that piece of work, because it crosses across a number of things. If we aren't able to do that, we just need to identify someone that moves that work forward. The second red area is around climate adaptation. Now, we are all being asked to do this. So George Eliot, we've been asked to do this and have a plan. There's a cost to that. So what we've done instead is we've asked whether the Integrated Care Board can do it on behalf of all of us. So we're just waiting to find out if they'll take that forward, but hopefully they will, and that cost will be less, but also the learning is the same for all of us and the plan will be pretty similar for all of us. So it seems like a good way to work with the system. And like you say, Chair, we will be discussing the integrated energy solution in confidential, which is a large part of our plan, and we had a really good discussion on that. I think maybe my reflection is next time to board, as part of this regular update, we'll do a deep dive and a focus on our energy consumption around what we're doing about that and providing that assurance and that opportunity to challenge whether there's more we can do. I'm happy to take any questions.
Thank you, Sophie, for being with us today at the board. Sophie's suffering from a COVID, so we appreciate you persevering. Questions and perspectives to Sophie on the Green Plan update? Apologies for my ignorance, Sophie, and you may not know the answer. If I'm a citizen, do the buses run on a Sunday past the hospital?
They do, but we know we've got an issue with travel and transport in general to Warwick Hospital. We do have an opportunity to feed into local plans, and that will be, Adam is going on Friday. And although that's the district council local plan, I think whenever we get the opportunity to work with the council on this subject, as an organisation, we need to push travel and transport. So yes, you can, Russell, but it's not ideal. And we know some of our residents in South Warwickshire have to have like 2 or 3 buses to get here. So on a Sunday, that's not practical. Yeah,
I think the issue of weekend bus availability, particularly if you've got an aged loved one who's in the hospital and you're aged as well and you can't drive anymore, is a disproportionate issue for our older patients. So Adam, can you take this forward? And John Holland is one of our stakeholder governors. It might be worth having a chat to John to see if John can help encourage this, because we talk about carbon footprint and being more green, but there's nothing, well, there is, you can walk or ride a bike, but buses are far greener than driving by car. But also, if you're old and you're unable to drive, you do either rely on buses or Uber or a loved one. So can I leave that with you? I think it is, I know, a really big issue for some older people. Thank you, Sophie. We'll move on then to the Audit Committee report for the 20th of June. Richard, thank you for dialing in from your holiday. Anything you would particularly like to pull out for this?
There's a report for our taken as read, but the two main things we did at that meeting was we largely approved the annual accounts, and I confirm to the board that they were submitted by the 30th of June and presented to Parliament before the summer recess. So all credit to Kim, Ravi and Mick, and special mention to Sue Bunn, who did an excellent job on the annual report. So it all sailed through. Lots of other trusts never met that deadline, and we didn't last year, so it's a really good improvement. And then as well as that, we had the annual internal audit report and head of the internal audit's opinion, which provided significant assurance.
Okay, thank you very much, Richard. Any questions to Richard on the notes of that Audit Committee of the 20th of June? Thank you, Richard, and thank you everyone involved in the Audit Committee for your hard work, and well done, Kim and team. The Clinical Governance Report for the 12th of July and the 9th of August. David, anything you particularly like to pull out?
I don't think particularly. I think it's fairly clear from my notes, but I'd be happy to take any questions if people have got them.
Okay, thank you, David. Any questions or perspectives to David on those two reports? David, you're Chair of Clinical Governance. You also share with me the responsibilities maternity and NED safety champion. Anything you would like to say regarding this terrible Letby situation and how your level of assurance about the maternity services at SWFT?
Yeah, I mean, obviously, I've liaised with Fiona and Charles, who are going to present a full report to the Clinical Governance Committee next week. So hopefully at our next board meeting, I'll be able to give some fuller assurance. But we certainly appear to have processes already in place in SWFT that are robust. I think it's really important to note that, and we shouldn't predict what the inquiry into Letby will come out with, but undoubtedly culture within the trust will probably be criticised. We do not have that culture within our trust, and so I'm fairly confident that the situation would be different in the similar circumstances. And the other thing that you've already sort of alluded to, things have moved on since Letby. For instance, Speak Up Guardians not being the least of those, but also the way some deaths are reported and investigated change. So, I mean, I'm really confident, and was, gained even more confidence from Lorraine's intervention earlier, and indeed communication we've had in between. So, I think SWFT, we mustn't get complacent, because no matter how good we are, there will always be the possibility that there is another Letby out there. Thankfully, they're very rare, but unfortunately they happen. And I think it's really important that we realise it isn't only neonatal nurses that do these crimes. It can be in absolutely any department in the hospital, or indeed the community. And I think we've got to, as a trust, make sure we've got as many processes in place as robust as possible to identify any potential individuals like this, but then also to make sure we've got the culture to deal with them appropriately when they are identified. So hopefully a fuller report next meeting.
Okay, thank you very much, David. Very clear. Any questions to David, Charles?
Yeah, I would just like to echo what David said, but one of the telling things to me about the Letby case is actually the clinical director for the neonatal unit had worked out what was going on 4 weeks after the first cluster of deaths.
Yeah,
and the most difficult issue is the point that David made out, that a homicidal healthcare worker can be very difficult to detect. So, in the Letby case, the pattern was seen, that the deaths were reviewed actually very promptly, but that there was a failure to take action in a timely way.
No, thank you, Charles.
Yeah. I think can I add to that? I think it's really important as a trust we do always consider the unthinkable. I have communicated that to my non-exec colleagues, but in almost invariably, the problem here is the people don't want to consider what seems to be really improbable. And in these sort of situations, you've got to consider that.
Yep. Thank you, David. And Charlie's on the call as well. And I know she does fantastic work in this regard. Okay, team, we'll move on then to the summary of ratified policies. Adam.
I will take this as read. There were a lot of policies this month, but I'm happy to take any questions.
Thank you. Adam, any questions on the ratified policies? Okay, duly noted. Thank you. We've then got the updated register of directors' interests. Sarah, anything you particularly like to highlight?
Thank you. So this register actually captures an update from Kim, but to clarify that Russell and Glenn's declarations of interest, which you raised at the beginning of the meeting, will also be captured on the register before it's published on the website.
Thank you very much.
Take any questions. Thank you.
Any questions on the register of interests? Okay, thank you, team. So we move on then just to the board committee minutes. The audit committee of the 7th of June. Richard will take as read. Any questions from colleagues on these? Okay, thank you. Then the clinical governance, as we said, the 14th of June, the 12th of July, will take as read. Any questions on these? Please raise a digital hand. Okay, thank you. And thank you to everyone involved on all of those committees, as I said earlier. Any other business colleagues, please raise a digital hand. I can't see any hands raised. We'll move on then to questions from governors and members of the public. I think we've had a couple, or we haven't had any. So we've got a few minutes. We've got members of the public on the line. Any questions from members of the public? Could you please raise a digital hand if you do? Okay, I can't see any digital hands raised, so I will therefore draw the meeting to a close and say we look forward to seeing you at the next board meeting. I always forget the date. Sarah, what's the date of the next board meeting, please?
And on quickly, it's the 4th of October.
Thank you very much. And Simon Page, I think, will be chairing that for me. In the meantime, everyone, take care. Thank you all very much for your hard work. Board colleagues will have a 10-minute break, get back together again at 3:45 for the confidential board. Take care, everyone, and get your COVID jab and flu jab as soon as possible, as soon as you're invited. Thank you.